Welcome, everyone. My name is Stefaan Verhulst. I'm the co-founder of GovLab, and I'm delighted here to have française, Onyango and Chinwe Ochu join today to reflect on what is the current state of COVID-19 in Africa, but more importantly, perhaps also what's the role of data. And today's webinar takes place within the context of the data for COVID-19 challenge in Africa, which is a challenge that is organized and supported by Agence France de Développement, Expertise France, and the GovLab as well. And within the challenge, we have engaged 7 teams across the African continent on really trying to innovate how we leverage data in order to understand, prepare, respond, and hopefully recover from COVID-19. And today we have 2 representatives from 2 teams, one from Kenya and the other from Nigeria. And let me start by asking each of the participants here to briefly introduce themselves, meaning I have your bio here. It's a very long bio, but I thought, why don't we ask you to introduce yourself, because you might know what you wanna share with the audience on how you would like to be known. And let's start with Chinwe Ochu. And so, Dr. Ochu, why don't we briefly hear from you who you are, what you do, and how it relates with what we're going to discuss today as well. Over to you.
Thank you very much, Stefan, and good day, everyone. So I'm Chinwe Ochu. I'm a medical doctor and a public health specialist that work with the Nigeria Center for Disease Control as Director of Prevention Programs and Knowledge Management. In my department, I coordinate and supervise the Infection Prevention and Control Program, the Antimicrobial Resistance Program, the Nigeria Field Epidemiology Training Program, the Risk Communication Program, and I also oversee lots of other donor projects and management. So research, training, and knowledge management is supervised by my department. And for the COVID-19 outbreak, we were able to initiate a consortium that brought together various researchers from research institutes and policymakers alongside scientists from the academia, a lot of other partners, including those from the industry and private sector, to look at the WHO roadmap, research roadmap for COVID-19, and to identify our own country priorities to enable us scientifically provide evidence that will support the response, and that has been tremendously helpful in the response in Nigeria. So this is my role. I'm also an associate professor of the Center of Excellence for Migration and Global Studies of the National Open University of Nigeria. So these are the roles I play at the Nigeria Center for Disease Control in brief. Thank you.
Great. Well, thanks so much, Chinwe, for joining. Sounds like you're a very busy person, and so we appreciate you sharing an hour of your time with us to really reflect on some of the issues that we jointly work on here together within the context of the challenge. And now over to française Onyango. Française, over to you.
Okay, thank you so much, Stefan. My name is française Obare Onyango. I work with the Population Council based in Kenya. My background is in demography and population studies. And at the Population Council, I mostly focus on conducting research, and also I oversee the data management unit here in Kenya. At the Population Council, we conduct social science, public health, and biomedical research to generate evidence to improve lives around the world. And in relation to COVID-19, since the pandemic began here in Kenya, we have collaborated with the government to conduct a number of studies that have informed some of the risk communication strategies. For instance, we conducted knowledge, attitudes, and practice surveys that have informed how the government basically communicates about the pandemic based on people's perceptions and attitudes about the pandemic. We have collaborated with the Office of the President to conduct a study to examine the impact of the disease on basically the socio-economic impact of the disease on households. We are collaborated with the Ministry of Health to conduct a COVID survey among community health workers, basically to determine the extent to which the pandemic has affected health service provision at the community level. And right now we are also collaborating with the Kemily Wellcome Trust to conduct a similar survey among now healthcare workers, facility-based healthcare workers, basically to explore issues of vaccine acceptability, hesitancy, and supply chain. So in brief, that's what we do in relation to COVID, but we conduct research in other areas like reproductive health, HIV/AIDS, and issues concerning adolescents and youth. Thank you.
Great, thanks so much, Francis, for joining as well. And so why don't we go straight into some of the questions that everyone has here, which of course is related with first of all, the current state of COVID-19, but also I think what is very interesting from my point of view is the whole discussion, of course, is to what extent is COVID-19 within Africa different than other continents, for instance. And there has been a lot of discussion about that. Anyway, it has been a different experience. Of course, anyway, it has been devastating in many ways. But also what would be interesting is that are there some lessons that, anyway, based upon what we have seen so far, some lessons with regard to Nigeria or Kenya that anyway we should know as a global audience. And so why don't we start with Chinwe. So what's the current state? Meaning there's a lot of press coverage of a third wave of COVID-19. And of course, it depends on, anyway, whether it's South Africa or other parts of Africa, I guess, as well. But what's the current state in Nigeria? And also, anyway, looking back now that we are, anyway, what is it, 16 months or longer in the pandemic, looking back, what anyway, are there some unique trends within the African continent that you feel is important emphasizing as well? Over to you.
Thank you again. And I think the African experience has been a very interesting one. Like you rightly pointed out, the trajectory of the pandemic in the continent had been very surprising to not just us, but to the whole global community. At the initial phase of the outbreak, everybody expected more severe outcomes because of a lot of social and demographic issues in the continent, but that wasn't really the case. And so that threw up a lot of questions, which I believe the whole world is still trying to answer. Some things are getting clearer, but there are still a lot of unanswered questions that we need clarity on. In Nigeria, we started with the first case 27th of February last year, and went through the first wave. Initially, the cases were limited to those that were restricted to those that were coming into the country from other countries, because the primary source of the outbreak was not in Nigeria. And our public health response then focused more on limiting importation. But within a short while, in just a few months, and I think what helped us slow down the outbreak was the proactive response of travel bans and then lockdowns that happened quite early during the outbreak. But we eventually got to a community transmission phase that led to the first wave that we had, got to the peak and then came down with a lot of intensity of response, public health response. For us as a country, we can look back now and say, yes, this was what worked for us. There was this political strategic leadership over the response. Just after the first case, a few days after the first case was recorded in the country, right from the office of the presidency, the presidential steering task force was constituted that really helped a lot in mobilizing resources that we needed as an MPHI to be able to work. And then, of course, we had a system already in place that enabled us to respond to all the other outbreaks. As it was, we were already responding to the Lassa fever, a very large Lassa fever outbreak, and we had an activated emergency operations center for Lassa fever before we detected the first case of COVID. So it was not that difficult to translate that to a COVID-19 response. So we had that multi-sectoral approach with that platform that brought together different partners and stakeholders to respond to the outbreak. And then another key thing that helped us was the use of data to drive the response. There was a lot of epidemic intelligence that we derived from looking at data. For Lassa fever and the other disease outbreaks, we had a digital software we call this Surveillance Outbreak Response Management and Analytical System, as SOMAS, that enabled real-time reporting of data. So we had deployed this to several states of the country before the COVID-19 outbreak. So we then scaled this during the COVID-19 outbreak to all the local government areas of the country. We had about 774 of them. So we also had this software, this analytical software at our points of entry. So once a case is detected, it's imputed real time, and we get the information at the National Public Health Institute, the Nigeria Center for Disease Control. We have a dashboard that displayed it. And we had a lot of partners that supported us in data analytics and everything, helping us to use data to take immediate decisions on a daily basis. So that helped us a lot to be objective, especially in the face of overwhelming public, public concern and all these suspicion and rumors and conspiracy theories. So many things were happening that could deter us from the response, but data guided us and helped us to remain focused. So that was a very key thing. And then from the beginning up to the second wave, down to what we are experiencing now, we've been having regular polls and surveys, collection of data from the public to understand their perception, and that had helped our crafting of our risk communication messages. So these are key things that have happened in this outbreak for us as a country that was a bit different and helped us. One big challenge, I'm sure we're going to get to that later, is public distrust and misinformation, what we call the infodemics and everything. So this data helped us to address misinformation. Data helped us a lot. So where we are currently, we have been through the first wave, the second wave, and we have seen the numbers start rising. And our experience has been that anytime we start going to the trough of the wave, people relax on the public health and social measures. There's flagrant disregard for public health protocol, preventive protocols. People don't wear their face masks, and then we'll start seeing the numbers rising again. So this is where we are. We are gradually climbing the slope of the third wave. Maybe I'll stop here and then continue as we progress. Thank you.
Great, thank you so much. That was a really detailed overview, and indeed I will come back to some of the topics that you've raised as well. And so similar kind of question to you, Francis, but given the fact that your specialty is demography, would also be interested to learn whether different populations were affected differently as well, because I think that's one of the other aspects of course of which at the beginning of the epidemic there was like a lot of conversation about, is that everyone is equal when it comes to COVID-19. It turns out that that is not the case, that indeed certain vulnerable populations were perhaps more affected than others. And so interesting to hear from you, Francis, what the state of play is currently in Kenya, but also whether there are some anyway, there is some kind of disaggregation on the impact across demographic groups in society. Over to you.
Okay, thank you, Stefan. I would say that there's quite some similarities with the Nigerian experience, especially in terms of national response, because the first case in Kenya was detected in March 2020. And right from the beginning, the Office of the President was involved, took charge, and a national committee, response committee was set up, headed by the Ministry of Health, basically to coordinate the response and mobilization of resources to respond to the pandemic. And this brought together players both from the public and private sector joining hands to respond to the pandemic. So I can see a little bit of similarities there. And in Kenya, we have gone through basically 3 waves. The third wave was early this year. And based on affected demographics, basically the elderly, the most vulnerable were the elderly, but given school closures and as a result of the pandemic, that also affected young people, mostly girls. So there were these media reports of increased teenage pregnancies, issues of domestic violence. So those are some of the consequences of the measures taken to prevent COVID-19. But essentially it played a role, those measures played a role in slowing down the spread of the pandemic, such that, okay, it started as an urban thing, mostly focused in Nairobi and Mombasa. But with time, we started now seeing the community spread, but it was not with the kind of bang that was expected, as Chinwe stated, but it was something like gradual. And this was partly attributed to the measures that were initially put in place to control the pandemic. So basically, in terms of data, I can say quite so many players have played a role, both state and non-state actors. Like for us, we are non-state actors, and when the pandemic came, we took seize of the opportunity to figure out how can we use the surveys we have been conducting to generate rapid evidence that can inform government response. And for the government also, like the government agency responsible for statistics, the Kenya National Bureau of Statistics also started conducting rapid phone surveys just to assess the status of the pandemic. And all these have came in handy to inform the government response. In part, the National Response Committee basically played a key role in basically coordinating all this information and making sure that accurate information is channeled out there. But as Chinwe says, the misinformation is still a challenge. And even as now people become to know more and more about the disease, we still have to deal with misinformation. Thank you.
Great. Thanks so much. And so why don't we unpack indeed the, because obviously this webinar is part of the data for COVID-19 challenge. And so why don't we unpack the role of data, but also what are some of the lessons learned from the experience? And so one of the elements, Chinwe and Francis, that we focused on was at the early beginning of COVID-19 was to really try to understand, well, how can we have some sense of the key questions that we need to answer in order to actually, deal with the response or deal with, the early phase of the pandemic. And then also think about what are the questions that evolve as the pandemic evolves. And I was wondering, to you, Chinwe and Francis, whether there was actually, you mentioned that there was this dashboard that was updated in real time, and also, Francis, you mentioned the use of surveys. But wonder from your point of view, were we prepared with regard to an understanding of what the questions were that mattered for which data could help. And that might be perhaps a hard question in itself, but I'm wondering anyway, if there is anything that we've learned from this pandemic, perhaps, is that we actually do need to have an understanding of, anyway, if a pandemic hits, we need data on those topics, right? And so I'm wondering whether that was available or whether this was a learning experience in its own right. And if so, how would you go about moving forward to prepare for the next pandemic? So let's start with the questions, which I think quite often is ignored when we talk about data. It's all about data, but what are the questions that matter? And so over to you, Chinwe.
Thank you, Stefan. I think these are very interesting questions that you are raising, thinking about what questions really matter. Like you rightly noted, it was a learning experience for all of us. This was a pandemic like none other. And for us as a country, it was more or less the first pandemic that we really had to deal with as a nation. So a lot of questions were there, the kind of questions you want to ask if you have a novel virus that nobody in the world knew anything about, so to say, what was happening. So there were so many questions, and I'm really thankful for the leadership role that the WHO played in kind of helping us to organize our thoughts on what kind of questions we should be asking. But you will agree with me that there were a lot of contextual differences that meant that each country needed to ask its own questions. Each continent needed to understand what really mattered and what are those challenges and the peculiarities of our context that we need to address. How do we even collect data that can inform and guide us in our response to various different challenges? For us in Nigeria, I think the lesson we have learned is that it's good to have triangulate data sources. And not just, before now, we had given placed a lot of emphasis on traditional epidemiological data. So, and that is what the software I talked about, the routine surveillance data provided for us. So it was easy to assess and very, very useful in taking quick decisions. But beyond that, we needed to understand what the perceptions of the people that we are working with and the communities and the Nigerian population, what were the perceptions, even the perceptions of different population groups, some of whom could be more vulnerable than others. So that was very clear with this pandemic, that there was need to go into, polling through social media, sending out questionnaire online, telephone surveys, all manner of methods used to try to understand what was responsible for the different behavioral trends that we saw through the outbreak. And that has been pretty useful. I'm so happy that now with this data for COVID-19 Africa Challenge, we have some data sets that we can look at now. And I'm so thankful and grateful that we're able to collect those data during the heat of the outbreak. We worked together with a lot of partners, like the NOI polls, that's Ngozi Okonjo-Iweala polls. They were doing weekly polling, and that guided our risk communication efforts. So every week, we wanted to know what was the trending news, what were the perceptions of people, and what do we start dealing with now? Should we focus more on physical distancing, on wearing of face masks, and all that kind of stuff? So they were doing that regularly, and that helped us. Now, secondly, as a National Public Health Institute, we started a remote management system that was based on these kind of non-traditional data that were coming from our call centers, coming and then going to our Twitter and all the other social media platforms to try to understand what were the trending rumors and to classify them. Now, using a systematic way to understand, are these harmful messages, these kind of these rumors that we are bringing out, are they misinformation? Is it something that is a risky behavior? And how do we deal with it? So we began to use data to guide our risk communication messages. And that was a big difference. So that led to the development of a risk communication and community engagement strategy that clearly outlines how we manage rumor. So that was very, very key. So data has been critical and the questions have been evolving.
Right.
We didn't start with all the questions, but we kept asking questions as follow-up to questions that we had already addressed. And as we observed the trend of events, more questions came up. And all these questions are usually addressed through data, both traditional and non-traditional data sources. That has been very, very helpful. Thank you.
Cool. So Francis, also you referred to some developments that were associated with the impacts, for instance, of actually non-health interventions such as lockdowns and so on, and the impact on teen pregnancy and domestic violence. So wonder how did you start with what are the questions that matter from your end that also had a broader perspective than perhaps pure health related kind of infection rates, but also looking at the second order kind of impact that certain kinds of interventions might have, and how would you what's the lesson learned? Is that is there a need for a collection of questions that says, look, if another hits, we need to start thinking about those earlier on, for instance? And I think it was interesting from Chinwe to say is that perception was actually a critical data point, right? In order to inform the risk management strategy and mitigation strategy. Over to you, Francis.
Okay, thank you, Stefan. Interesting question here, because I remember earlier on in the pandemic, the Minister of Health in Kenya narrated on television how he'd spend the night looking through for information, because the first question was, what disease is this? Okay, understanding the disease was the first question before you can understand how to respond to it. So he narrated how he would spend the nights looking for information from any source that would later guide government decisions regarding the response to the pandemic. And then as more information became available, especially I remember at the beginning, there was even confusion of whether face masks work. But now as WHO now came to clarify issues, people adopted face masks. This other question was now focusing on the people themselves, okay? How they respond to these prevention measures. And that again now brings in the question of understanding perceptions, attitudes, and practices around the pandemic. And as we were addressing this now, another issue came up now with the prevention measures. What are its consequences on various segments of the population? So basically, these were very critical questions to answer as the pandemic evolved. And interestingly, both state and non-state actors came together to feed in the much they could at the time. But the critical lesson here for us was that some systematic surveillance of disease is necessary because from that information, we can be able to model disease patterns. And for instance, in the Kenyan case, for instance, even with the very limited information available, modeling has been key, because I remember towards the end of last year, the modeling showed that there would be a peak in around March, April this year. And it came to pass because we experienced that peak. So you see the kind of role data plays, and that modeling then helps to plan basically. What do we do? We have modeled that there will be a peak in March, April. So what do we need to put in place to make sure that we respond effectively? So that's also an important role that data plays, planning. And the other thing about important role for data is basically designing the risk communication strategy, okay? Based on what we know, based on data we know, how do we then communicate to people so that they take up the prevention measures. So I think for me, those are key critical questions that data played an important role in answering during the pandemic here in Kenya. Thank you.
Great. And of course, one aspect anyway, and again, you both already referred to the issue of misinformation and distrust in general. But obviously, once we start using data, one key concern is also distrust in how the data is being used and how it is being collected. And so wondering how you approach that, whether there are governance structures in place within both Kenya or Nigeria that you comply with, or that sets a standard on how you go about leveraging data, especially when you in a time of crisis, when everything has to be done quickly, but also when you start using non-traditional data sets such as social media and other forms as well. And so how did you deal with that within your particular kind of context? Chinwe, sorry.
Another very interesting question. Yes, because of the emergency situation, and we need to, yes, use data responsibly, make sure that the information that we're getting from data that we have are valid. So I think we rely, a lot has to do with capacity in this regard, being able to manage data effectively. That is an area that I know we still have a lot of gaps in the African setting, but we have expertise both within and outside the country that we're able to leverage to support the management of data during the response. For us in Nigeria, we already had capacity in place at the National Public Health Institute. We're already managing other forms of data for disease outbreaks, and it was easy to, utilize the same methodology in addressing COVID. But more than that, we had a lot of partnership, and I really want to appreciate the role that partners play in this type of emergency situation. We collaborated with statisticians and experts from universities, the academia, and those that were really good at managing data, modeling, and making sense out of the routine data that we collect. So that was very, very useful. So a lot has to do with capacity, because of course, most of these that we do, we publish also in peer-reviewed journals, and they will scrutinize your methodology and everything for those that were clear research projects. And so it was very, very useful to us that we had the support of all the experts that we needed for the response. So that is very, very good. Another key issue that, a key lesson that I think we need to learn from this is the importance of health information management, having a good HIMS that collects regular data in a way that makes it easy to be utilized to inform public health actions. So strengthening the HIS in the country is something that we have learned and we are trying to do as a nation, and the role that it has to play, right from the health facilities to the disease surveillance and education officers in the primary healthcare centers, up to the state and then the national level. So the health information system is key. And if we're able to strengthen the data sources from these regular routine HIS, then it becomes easy for us to use data in a way that we can interpret it to guide our actions. These are some of the key lessons from our own context. Thank you.
On the just one follow-up question, and then I go to Francis. On the anyway, health information management system. So give us a little insight on how Nigeria is organized, and what, anyway, is it provincial, state level, is it federal, and how would, anyway, how would you, anyway, build a national HIMS system, or is that, anyway, is that already, anyway, because how you're organized, is that already a feasible?
Yeah, yes. Yeah, Nigeria is a very unique country. We operate just 3 tiers of care. We have the tertiary, the secondary, and the primary healthcare systems in the country. Health information system, we are still growing in it because we have a plurality of approach in different settings, differences in the way data is managed across the various levels. While some have, started using electronic data system and they've digitized all their information. Others are still using, paper-based HIS, and that is the challenge. So you discover that in some areas, you still have to deal with a lot of missing data and, difficult to manage data for those that are not yet digitized. So in Nigeria, we have a health information management system that is coordinated from the federal level. And there are also associations. I know we have a national health information management system that brings together key players from the ministry and non-governmental organizations that deal with HIS. And they are really advancing towards having a system that works and is able to coordinate data from the various levels so that at the national level we're getting it. But in the public health sector, for Nigeria Center for Disease, I think we've made a lot of progress in that we use an integrated disease surveillance and response system that has data flowing from the lowest level of care up to the national level, so in a coordinated manner. And bringing SOMAS into the picture has also helped us to manage health information very well in the public health sector. So as information and data is collected from the PHCs, they are transmitted real time to even the national level. And the states have a dashboard where they see all these things and data displayed. So we are growing. There's still a lot of gaps, but we are making a lot of progress. And I think the lessons learned from the public health sector can be scaled to all the other sectors of health. Thank you.
Interesting. Francis, let's go back to the question of how do we establish trust in how data is being handled? And you have long-standing experience with that, anyway, both in conducting surveys and other uses of other data sets. So what's the situation in Kenya from your point of view?
Okay, thank you, Stefan. Basically, as you note, establishing trust in data is important because as even for this, the COVID updates, at some point people are questioning where does the minister get those numbers, which he announces every day. So that trust is key. And in Kenya, basically, we have systems for clearing surveys, basically making sure that whatever studies we do go through scientific and ethical review. And in cases like emergency situations like the COVID-19, there are options for expedited reviews, and that's basically what enables various actors like us to generate rapid information because we were able to go in and ask for expedited review. And basically, being aware that, okay, this study went through some systematic review before the data is generated to be released, then that is a way of establishing trust. In terms of basically, additional layer to trust is basically once we have the data, how do we communicate? Who is communicating it, basically? That's also key because I remember in the pandemic, people trusted more updates from the minister himself than from anybody else. So when the minister is speaking, people have trust in what he's saying and basically believe the numbers. So the source of the information is also key in establishing trust, besides the process used to generate it. And basically from the Kenyan perspective, okay, we have, just like Nigeria, we have an HIS system run at the national level, and the public healthcare system operates at various levels. The lowest level is the community level, and this is where we have community health workers. These community health workers are attached to health facilities. And so any information they generate at the local level, they submit to the health facilities, the next level health facilities. And then it goes on, the facility then submits it to a higher level, and it cascades that way to the national level. But as Chinwe says, we still have gaps in the HIS. It doesn't capture all the information that would be needed for disease surveillance. They're just key indicators that it gives priority, but with time, as partners come together, look through the HIS, recommend what additional information can be incorporated. The government's always open to basically exploring what additional information do we need to incorporate in the HIS to inform decision making. So it's always a learning process. The HIS is not cast on stone, because always looking for opportunities to add critical indicators. Thank you.
Great. Yeah, and I think that's not unique to Kenya, Nigeria. I think that's an ongoing challenge worldwide, is to build that kind of system that indeed gives a signal, right? So why don't we focus on what you're doing within the context of the challenge, and also, anyway, what you feel will be the added value if we manage to extract insight as we hope to do. So Chinwe, can you briefly share with the audience what you are planning to do within the context of the challenge, and also, anyway, what you hope, if anyone sees this webinar, whether there is any support or any kind of area that would be useful also to be supported in whatever way. So why don't we start there?
Thank you, and I think this is a very important opportunity that the data for COVID-19 Africa Challenge has provided to us as a country to look back at some of the, especially the non-traditional data sets that were collected at various phases of the response, and to see whether we can understand deeper things from them. And I think this is also another additional way of ensuring that there is trust in the data and what we are getting from the data, because when you triangulate data sets, it either supports or makes you to want to ask more questions that you want to address. So for us in the Nigeria setting, because of the great role we have seen public perception play in the COVID-19 outbreak in the country, we want to look back at some of the data sets that we have to see whether we can understand what are the facilitators and barriers to compliance with the public health and social measures in the country. So we are collaborating. The Nigeria Center for Disease Control is collaborating with the College of Medicine, University of Lagos, using data that were collected through collaborative efforts from both institutions, both the ones they collected from the College of Medicine and the ones we collected from NCDC, the ones that were collected by Result to Save Life in collaboration with NCDC and some of our other partners. So at various phases of the outbreak, some were collected during the first wave, some during the second, and some across the various phases. So we will be looking at it to address specific questions. The major question is to look at social, economic, and political factors that influence knowledge and perception of COVID-19 among Nigerians, and how such knowledge and perception shape population behavior and response to COVID-19 safety protocols. So specifically, we'll be looking at the social, economic, and political drivers of people's compliance with federal government of Nigeria's stay-home policy. During the lockdown period, we know we had varied response to an adherence to the lockdown. So we want to look back now and see what could be the social, economic, or political factors that influence how people complied to that stay-home policy. That could guide us in future outbreaks to know how to address that. Then secondly, we want to look at the financial realities of Nigerians and how that influenced their response to the COVID-19 protocols. Fortunately, we have data that assessed earnings from people and their financial or socioeconomic status. So we will look back now and triangulate data sets to see whether we will understand better how the financial realities of Nigerians affected their response to the safety protocols. We will also look at places where Nigerians are more likely to visit despite government's stay-home policy, because we want to prioritize, we want to scale them and say, where are those public places that people are more likely to visit even when there is a lockdown or when there is a stay-home policy? And how can we now better organize those places to reduce infection risk in the future? Like, for instance, the marketplace, and some are religious gatherings and things like that. Are there places that, looking at our data sets, the various data sets collected, that we can see that people are more likely to visit, and how we can organize those places to reduce risk? We will also be looking at the first wave and the second wave to understand changes in public risk perception and risky behaviors through these phases, the first and the second waves, and what relationship that had with risky behaviors to the trend of, and the risky behaviors, the relationship between the risky behaviors to the trend of COVID-19 infection. This also further underscores the importance of data, because if we had not collected this data before now, we will not have anything to look at. And finally, we want to see how government's non-pharmaceutical initiatives affected public trust in government and people's compliance with safety protocols. Like my colleague in Kenya said, trust has to also deal with who is it that is trying to communicate that information to you or that message to you. So we want to know what's the role that government played and the non-pharmaceutical initiatives affected public trust in any way, and how people complied with safety protocols. So these are very important questions that we want to address. Unfortunately, we have a couple of data sets that will help us to do this. We've had an inception meeting in March where we brought together the various stakeholders, policymakers, top-level policymakers like the Minister of State for Education and every other person that is relevant in making policy, and even the implementers. And we introduced this project to them and created a demand for the output from this project. So we've had the first data camp, 5-day intensive data drill, where we cleaned up the data sets and tried to organize them in a way that we will understand them, we'll be able to address our research questions. We're having a second data camp coming up soon. Hopefully by the time we are done with this, we will be better informed and understand what it is that drive people's perception and behavior. Thank you.
Excellent project, and thanks for this comprehensive overview. And I'm also sensitive to the time. We have like 4 minutes left. Francis, why don't you share briefly also what you plan to do, and if there are any questions, and there is already a question to Francis as well in the chat here, which asked how one can access HIS data in Kenya, and what are some of the indicators that are captured by the system. So Francis, if you also could address that question, if at all, in addition to what are you trying to do within the challenge, and then we will try to round it up by asking both of you, just give you a heads up on if you would have a magic wand, what would be the data set that you would like to have by using that magic wand. So over to you, Francis. What is the project, and then also perhaps the question here, and then you can also anyway reflect on the magic wand, and then Chinwe, you will be the last person. You will have the last word of this session. Francis.
Okay. Thank you so much, Stefan. I'll start by answering the question. Okay. There is a link for the DHIS data. I don't have it offhand, but I guess my email is in this communication. I can get it and share it. And then you just go there and you register. They'll ask you for a brief description of what you intend to use the data for. Basically they'll give you access. So the most of the indicators, when the HIS was first started, it was heavily focused on maternal child health indicators, issues to do with family planning. So you might find that for now it's quite heavy on those, but with time, a number of indicators have been added. I don't have them offhand. For instance, there have been plans to add indicators, for instance, like the gender-based indicators of gender-based violence and stuff like that. So I don't know how that have gone, but I know it's heavy on maternal and child health indicators and family planning. Thank you. For the challenge, what we are planning to do basically is to use existing data that we collected at the council, and this a longitudinal survey on knowledge and attitudes and practices related to COVID-19, conducted repeated times for over a period of time for following the same cohort, and basically to examine how do perceptions about the pandemic influence behavior, adoption of protective behaviors. And adoption of protective behaviors, here we are referring not only to the normal ones, known like wearing face masks, keeping distance and washing hands, but also issues to do with vaccine acceptability. Because as we did more rounds of the survey, we added questions about vaccine acceptability. So we want to see, basically using new techniques like the data science and machine learning techniques to understand how do perceptions influence adoption of protective behaviors. And we want to complement this with the non-traditional sources that Chinwe alluded to, and this basically mostly data from Twitter. To see how perceptions over time, basically public perceptions of the disease over time are changing, and in what direction are they moving, and what does this mean now for basically predicting future risks, prevention, adoption of protective behaviors over time. So in a nutshell, that's what we are looking for. And in this one, we are partnering with the Busara Center for Behavioral Economics to undertake the activity, and they are the experts in data science and machine learning. So we are really looking forward to the work, because it's a new partnership, because this is basically a new partnership we have been forging with various partners like Busara Center and Kemri Wellcome Trust to understand the pandemic and generate data that can inform programming and response to the pandemic. So what is this magic wand? Now, for now, the magic wand that everyone expects is that the pandemic can go away.
Sure. Yeah. No,
So,
obviously that would be the ideal. That would be the ideal. But if you would have,
it is here with us. Okay.
Right.
So for now, I think the concern for us here is vaccine availability. And if it is available, the acceptability. So that, and this basically is important because of the reports coming from other settings, showing that in countries where vaccination coverage has gone up, infections have reduced and stuff like that. And this provides some optimism that, okay, if the vaccine can become available in our settings, people accept it, then I think we can see infections reducing. Thank you.
Thanks, Francis. Chinwe, you have the last word. If you and anyway, specifically, I would say if you have a particular kind of data set that you say, if we only had that one, then we would be able to make progress rapidly. And again, thanks, Francis, for indeed we didn't touch on even vaccination at all, but obviously that's key moving forward, right? So Chinwe, you have the last word, and then we will close the session.
I think I like the idea of Francis what would make the virus go away. That's a very good one. And I think, yes, if we can have a data set that addresses equally epidemiological, virological, and behavioral risk factors to COVID-19, that will help. I think that to me will solve a lot of problems. Most times these data sets are all in isolation. So what data can tell us about whether COVID-19 is a syndemic and how to address the overall impact of COVID-19, I think to me that will make a whole lot of difference, especially in the African context.
Great. Wonderful. Well, Chinwe, Francis, thanks so much for sharing your wisdom. I've learned a lot, and I hope the audience learned a lot as well. And again, as said, this was recorded and will be made available for a broader audience. So I'm sure many people will learn from all your insights here, and looking forward to keep on collaborating in the context of the challenge. So thanks so much and stay safe. Bye-bye.
Thank you. Bye.